Hi everyone, this is Dr. 𝗕𝗵𝗔𝗟 and welcome to NEET PG Core Revision series. These series are structured, focused and exam oriented so that you can recall faster and more confidently in your exams. In today's session, we are going to break down the brainstem into clear, high-yielding, exam-focused concepts. So let's get started. So the brainstem is the stalk-like part of the brain which connects the spinal cord below to the forebrain above. And from above downwards, it consists of the midbrain, the pons and the medulla. So, if you see, the medulla becomes continuous with the spinal cord below. This is the spinal cord, so it becomes continuous with the spinal cord below. And above it is continuous with the forebrain, that is the cerebrum. So this brainstem, it is located in the posterior cranial fossa. Okay, so we will see the brainstem in this region, that is the posterior cranial fossa. Okay, so the midbrain is continuous above with the cerebral hemispheres, whereas the medulla oblongata is continuous below with the spinal cord. Now, just like the spinal cord, here also we have the nerve cells and the nerve fibers. But here the nerve fibers, they are arranged in longitudinal pattern. Okay, longitudinal like tracks, we call them tracks, we used to call them columns. Okay, we call them lemniscus, so that they are present in that form. And the cell bodies, as we see in the spinal cord, we see it as grey matter, right? But here we will see them as aggregate collection of this grey matter, which we call them as the nuclei. Okay, so they are just scattered and they form aggregated masses, which we call them as the nuclei. Now this brainstem performs various functions. So one is, it provides passage to the various ascending and descending tracts that connect the spinal cord with the cerebral cortex, okay, or the forebrain. And it also, so it provides a passage to the various ascending and descending tracts. It contains important autonomic reflex centers, that is, it has very important vital centers. Okay, so which are associated with the control of respiration, the heart rate, the blood pressure. And it also contains the reticular activating system, or otherwise known as the RAS. So this is responsible for the control of consciousness. Okay, and it also contains the nuclei of the 10 important cranial nerves. Okay, only the first, the olfactory and the optic, are in the region of the forebrain. The rest of the 10 cranial nuclear nerves, we will see it in relation to the brainstem. So the brainstem will be containing the nuclei of the other 10 cranial nerves, that is from 3rd up to the 12th. So that is why knowing the anatomy of this brainstem is very important, because bilateral destruction, okay, so bilaterally if the brainstem is destroyed or there is destructive lesions of the brainstem, it is very fatal. Okay, bilateral destruction is fatal. Why? Because it contains the vital centers. Okay, because there are vital centers in the brainstem. So, if there is bilateral damage, it can be fatal. And the impairment, and since it also has the reticular activating system, the impairment of this reticular activating system leads to progressive loss of consciousness and which is followed by stupor and then coma. So that is why the brainstem is very important. Now let's go to the first part of the brainstem from below, that is the medulla oblongata. Now this is the ventral view. This is the ventral view of the medulla oblongata. Now medulla oblongata is the direct upward continuation of the spinal cord. Okay, so it extends from the foramen magnum to the lower border, up to the lower border, and this is the pons, this is the medulla. So this portion is the medulla oblongata. So the medulla, if you see, it is truncated shaped like a cone or a bulb like. So that is why any lesion of this which causes paralysis, we call them as the bulbar palsy. So this medulla oblongata is about 3 centimeters in length, okay, and it measures about 2 centimeters in breadth and about 1.25 centimeters in its wider thickness. Okay, the widest part, it measures about 1.25 centimeters in thickness. So this medulla oblongata contains the vital centers. Okay, it contains the vital centers which are essential for life. That is, it includes the cardiac center, then we have the vasomotor center which controls the blood pressure, and then it also has the respiratory center. And if you see in this ventral part, it also provides attachment to the last 4 cranial nerves. Okay, so the last 4 cranial nerves, that is 9, 10, 11, 12, glossopharyngeal, vagus, accessory and the hypoglossal. So it also provides origin to these last 4 cranial nerves. Now if we see here on externally, just briefly about it. So in the midline, okay, we see the anterior median fissure. So the same fissure like how we see in the spinal cord, the same thing continues. Okay, so this is the anterior median fissure. And we see this side, the anterolateral sulcus. Okay, this is the anterolateral sulcus. Now this elevated part, what we see is the pyramid. It will be containing the corticospinal tract or the pyramidal tract. So that's why we call it as the pyramid. So this is the pyramid. And next to that, we will have, okay, one more elevation here, which we call it as the olive. Okay, so the olivary nucleus will be present beneath it, and this is the olive. So now between the pyramid and the olive, we will see the hypoglossal nerve. So this is the hypoglossal nerve or the 12th cranial nerve. And okay, and between the olive and that's it, we will have the inferior cerebellar peduncle, which will be connecting the medulla to the cerebellum. And there we will see from above downwards the 9th, the 10th and the 11th cranial nerves, that is the glossopharyngeal, vagus and the accessory nerve. So this is in the ventral aspect if you see. And if we trace the anteromedian fissure here, in the upper part there is a small foramen which we call it as the foramen caecum. So this is the foramen caecum. So this is briefly about the anterior or the ventral part of the medulla. Coming to the dorsal view of the medulla oblongata. So when we go to see the features of the posterior part of the medulla or the dorsal part of the medulla oblongata. So here we study in 2 parts. Okay, so the lower part is the closed part and the upper part is the open part. So in the closed part, we see 3 longitudinal swellings here, elevations basically, 3 longitudinal elevations from medial to lateral, which we call it as fasciculus gracilis. Then we have the fasciculus cuneatus, and we will have the inferior cerebellar peduncle. So these fasciculus gracilis and fasciculus cuneatus, as we trace it upwards, they form an expanded part, okay, which we call it as the gracile tubercle. And the cuneate tubercle. And this is the inferior cerebellar peduncle, which will be connecting the medulla to the cerebellum. Now this fasciculus gracilis and fasciculus cuneatus, they basically carry the sensations of pain, touch, temperature, vibration sensation, and 2-point discrimination, okay. So from the entire body. So the fasciculus gracilis will be mainly containing the fibers from the coccygeal, the sacral, the lumbar and the lower thoracic. Whereas the cuneatus will have from the upper thoracic and the cervical region, okay. So those. And here this expanded part, we call them as the tubercles, okay. So lateral to this cuneate tubercle, there will be one more elevation which we call it as the tuber cinerum, okay. So here there will be an elevation which we call it as tuber cinerum, and this tuber cinerum is basically due to the presence, or it is produced by the spinal nucleus of trigeminal. So this we see it in the lower part, whereas that is the closed part. In the open part, if you see, that is actually nothing but the lower part of the floor of the fourth ventricle. So this portion, this open part, it forms the floor of fourth ventricle. So here there is this median sulcus here, okay. So this is the median sulcus. These fibers are horizontally placed. White matter, we call it as the striae medullaris. And we see two triangles, that is the hypoglossal as well as the vagal triangle, okay. So here we will have the hypoglossal as well as the vagal triangle in this part. And also here we will see an area which is known as the area postrema. So basically this hypoglossal vagal, they will be having the nuclei of those specific cranial nerves, and area postrema is the center for vomiting. So these are some of the features which we see in the dorsal part of the medulla oblongata. So coming to the blood supply of medulla, so if you see the blood supply of medulla, so it will be supplied by the medullary branches of vertebral. Now this is the vertebral artery. So medullary branches of vertebral artery, medullary branches of anterior spinal artery, and here we have both of them joined to form the basilar artery, so that also the medullary branches will supply, as well as the branch of the basilar, that is the posterior inferior cerebellar artery. So that also supplies. So the venous drainage is basically into the dural venous sinuses. So it is into the basilar venous plexus. Then inferior, so whatever is in that region, okay. So the inferior petrosal, so here we see the basilar venous plexus, the inferior petrosal sinus and the occipital sinus. So it drains into this, the venous blood, okay. So the venous drainage is basically into the basilar venous plexus, inferior petrosal sinus and occipital sinus. So most of the lesion of these medulla is basically because of the occlusion of any of these supplying arteries, okay. So we will come, before we go into the lesions, just understand some of the key features of those sections of medulla. So basically now the medulla oblongata, okay, so it will have the grey matter which is in the form of nuclei, and the white matter which is in the form of fasciculus or longitudinal bundle, right, of the nerve fibers, which we call it as fasciculus or we may call it lemniscus, okay. So, or tracts. So, here the grey matter here, if you see, we have the nucleus gracilis and nucleus cuneatus, to which the fasciculus gracilis and fasciculus cuneatus will come. Then we have the olivary nuclei, the nuclei of all these vital centers of respiration, vasomotor and cardiac center, and nuclei of all the, the last 4 cranial nerves, that is the 9th, 10th, 11th and 12th. And there are other small nuclei. It also contains this network of nerve fibers and nuclei, which we call it as the reticular formation too. And the white matter basically consists of the ascending, that is going from the spinal cord towards the thalamus and cerebral cortex, and we have the descending tracts coming from up above, that is from the forebrain, cerebrum and down, okay, to the spinal cord. So, we will see now when we see the sections. So, first important is at the level of decussation of the pyramids. So, when we say at the level of decussation of pyramids, so pyramid is nothing but the corticospinal tract, okay, which contains the pyramidal, or it is also known as the pyramidal tract and pyramidal fibers. So, we take a section at the level where these corticospinal tracts of the right and left side will decussate, will cross over. So, when we take a section at that level, what do we see? Okay, so here this is also known as the great motor decussation, okay. It is also called the great motor decussation. So, why do we call so? So, basically because these motor tracts are decussating. Now, here if you see the section, it looks like the spinal cord section, okay, but there are certain features which little differ from that of the section of spinal cord. So, now if you see, first let us see at the grey matter. So, the central grey matter. So, here we see, so we have the nucleus, this is the nucleus gracilis, this is the nucleus cuneatus, okay. So, we see them as narrow strips, okay, narrow strip like projections from the posterior aspect of the grey matter. Then here, okay, so the posterior horn as such, what we see in the spinal cord, the posterior horn of the grey matter, that it forms a projection, or it forms here it gets swollen up, and this we call it as this contains the nucleus of spinal tract of trigeminal. So, this is the nucleus, and above that we will see the spinal tract, okay. So, this is the tract of trigeminal, spinal tract of trigeminal, and this is the nucleus, okay. So, it will be, the tract will be just, that is why it is not shown in grey, only this is shown in grey. So, above that white, because tracts is, they are nothing but the axons. So, axons we see them as the white matter. So, this is, we see it in the posterior part. Now, here this is the corticospinal tract. Okay, this is the lateral, call it as the lateral corticospinal tract. Now, this is crossing here, okay. Because of the crossing here, what is happening? The grey matter, okay, is getting detached, okay, from the central part. The anterior horns, okay, these anterior horns which we see in the spinal cord, okay, the same thing when we trace it up in the medulla, lower part we see the similar thing, but because of the crossing over, here the anterior horns are detached, and these detached anterior horns, they form the nucleus of, spinal nucleus of accessory nerve, okay, and the supraspinal nucleus of, okay, spinal nucleus of accessory nerve, and the supraspinal nucleus of first cervical nerve. Okay. So that is these anterior horns form. So this nucleus of spinal accessory nerve will be extending from here downwards up to the fifth cervical spinal segment. Okay. Then the supraspinal nucleus, okay, this supraspinal nucleus, it gives off the efferent fibers of the first cervical nerve, and it will be continuous with the hypoglossal nerve. Then there is a diffuse zone, okay, diffuse network of fibers and scattered nuclei. This we call it as the reticular formation. Okay, this is called the reticular formation. So this is all we see, the grey matter there, and other than that we also see, okay, the white matter. The white matter here is in the form of these two. These are the anterior and posterior spinocerebellar tracts. Okay, so this is the anterior, this is the posterior spinocerebellar tracts. Then we have this one is the lateral spinothalamic tract. Okay, this is the lateral spinothalamic tract. Okay, so this is what we see in the decussation of the corticospinal tract. So this is the pyramid. This is where it forms the elevation and it goes, with which we call it as the pyramid. So this is at the level of the motor decussation. Next, when we study the section at sensory decussation. So these two are very important in the medulla. So at the level of sensory decussation. So here now when we see the section, okay, so what are we seeing? Now here if you see the nucleus, okay, so this nucleus gracilis, this is the nucleus gracilis, and this is the nucleus cuneatus, which are very pronounced, okay, they are very prominent. Then here, now what happens? From here the second order neurons, they begin and they will be decussating here, okay, they will be crossing over here. So if you see here, there is this crossing, and this crossing we call it as the sensory decussation. So basically these fibers are carrying, okay, sensations of discriminative touch, the pressure sensations point, okay, vibration sensations. So they will decussate in the median plane, okay, and then they will turn upward, and when they turn upward and they pass, we call them as the medial lemniscus. Okay, this is called the medial lemniscus. So in this decussation, the gracile fibers will be lying medial to the cuneate fibers. So these we call it as the internal arcuate fibers. So because of these fibers which are beginning from these the second order fibers which are beginning, we call them as the internal arcuate fibers, and they will be cutting off the spinal nucleus of, this is the spinal nucleus of trigeminal. So this will be basically carrying the sensations from the face, okay, so the ipsilateral pain and temperature sensations, okay, from the face, and forehead will be carried by the spinal nucleus. This will be coming to that, okay, spinal tract of the trigeminal. So now here this is the spinal nucleus and this is the spinal tract, okay. So these internal arcuate fibers, they will cut this, separate this spinal nucleus from the grey matter here. Then other than that, we also see here one more thing in addition, which we didn't see at the level of motor decussation. This is called as the medial longitudinal bundle. So this medial longitudinal bundle will be lying posterior to the medial lemniscus, and this is nothing but compact bundle of fibers, okay, compact tract of nerve fibers, which will interconnect the third, the fourth, the 6th and the 8th cranial nerve. Okay, so this will be connecting. Okay, so the oculomotor, the trochlear, the adjacent, and the 8th is the vestibulocochlear nerve. Okay, and the spinal nucleus of 11th cranial nerve. So this basically it will be containing the fibers which connect these nerves, cranial nerve nuclei. Then in addition, we are also seeing the spinocerebellar and the lateral spinothalamic tract here. These are the spinocerebellar tracts and this is the lateral spinothalamic tract. Now here the lateral and anterior, okay, the lateral and the anterior spinothalamic tract will together form the spinal lemniscus. So when we say spinal lemniscus, so this is nothing but the anterior and lateral spinothalamic tract together. So this is about the section at the level of sensory decussation. So now let's move on to the lesions. So the vascular disorders of medulla oblongata basically involves the thrombosis of posterior inferior cerebellar artery. Okay, so the area supplied by the posterior inferior cerebellar as well as the vertebral arteries and its branches. So whichever artery is occluded, okay, or ischemia, whatever happens of these, thrombosis of these vessels can lead to the lesions. Okay, so it results in what we call it as two things. One is the lateral medullary syndrome and the medial medullary syndrome. So before we go into that, let's understand a few basics of whatever tracts are present there. Okay, and what can happen if the lesion happens there. Okay, so we have the spinothalamic tract. Now spinothalamic tract, okay, what does it do? It basically carries the sensations of pain and temperature, okay, from the opposite half of the body, right? So that is the thing. So if any lesion of the spinothalamic tract happens, what can happen? There is contralateral loss of pain and temperature sensations. Then we have the spinal nucleus and tract of trigeminal nerve. So spinal nucleus and tract of trigeminal nerve is carrying the same side, pain and temperature sensation of the face. So on the same side, if this tract is involved, then it can result in ipsilateral loss of pain and temperature sensation. Then if the lesion involves inferior cerebellar peduncle, okay, and the cerebellum part, because that will be connecting there, it results in ipsilateral ataxia. Okay, so there will be ataxia, okay, imbalance there on this one side, on the same side of the lesion. So when we say contralateral or ipsilateral, contralateral is the opposite side of the lesion, okay, and ipsilateral same side of the lesion. It's in relation to the side of the lesion. Nucleus ambiguous, okay, so nucleus ambiguous, it results in the same side ipsilateral paralysis of muscles of palate, pharynx and larynx. Then if the vestibular nuclei are involved, it results in giddiness. And the descending sympathetic pathway and reticular formation, okay, because sympathetic pathway is involved, it results in Horner syndrome. So these are some of the tracts and nuclei when they are involved, what can result. Okay, so basically, as I said, in the vascular lesions of the medulla, we see two things. One is the lateral medullary syndrome. So this is the area involved in lateral medullary, okay, syndrome. This is also called lateral medullary syndrome of Wallenberg. Okay, lateral medullary syndrome of Wallenberg. So this is mainly due to the posterior inferior cerebellar artery involvement. This one. And the other lesion which we see commonly is the medial medullary syndrome. And this is the area which is supplied by the branches of vertebral artery. This is also called as the 𝗕𝗫𝗄𝗃's anterior bulbar syndrome. Okay, so these are the two things. So we will little bit look into what are the signs and symptoms which happens due to lesion in this area. So now we are aware of what nuclei, what tracts are present in the central part there and as well as in the lateral part of the medulla. So now we will first come to the lateral medullary syndrome of Wallenberg. Now lateral medullary syndrome, so basically here as the name says the lateral part. So the dorsolateral part of the medulla is basically supplied by the posterior inferior cerebellar artery. So this is usually a branch from the vertebral, but sometimes it can be also from the basilar. Now this artery, along with supplying the medulla, it also supplies the, as the name says, the inferior, okay, posterior inferior surface of the cerebellum. So the thrombosis, if there is a thrombosis, okay, so which we saw in here, thrombosis of the posterior inferior cerebellar artery will involve like a wedge-shaped area of the dorsolateral part of the medulla. Okay, and it will also involve the inferior surface of the cerebellum. So there will be both symptoms involving the medulla as well as the cerebellum. So involving the medulla, now what are we going to see? Okay, so in that portion, which tract we will see? We will see the spinothalamic tract. So because of which there is contralateral loss of pain and temperature sensations. Okay, so there is contralateral loss of pain and temperature. So in the opposite side, so if the lesion is on the right, in the opposite side there is loss of pain and temperature sensations. Then we see the spinal nucleus and tract of trigeminal there. So that's why there is ipsilateral loss of pain. Then nucleus ambiguus is present in that region that is involved. So because of which there is paralysis of same side, ipsilateral paralysis of muscles of palate, larynx and the pharynx. Vestibular nuclei, there is giddiness and descending sympathetic pathway, 𝗲𝗏𝗏 syndrome, that is meiosis, ptosis as well as anhydrosis. So these are the things which we see because of the lateral medullary syndrome of Wallenberg. Okay, so we see, okay, same side there is ipsilateral loss of pain and temperatures of the face and contralateral hemiplegia. Contralateral loss of, not hemiplegia, pain and temperature. Contralateral loss of pain and temperature. Here ipsilateral loss of pain and temperature on the face. So with this presentation of the patient, you should be able to recognize or at least say, okay, where could be the probable lesion. And in addition to that, there will be giddiness, okay, and Horner syndrome, which you can see meiosis, there is drooping of the eyelids, okay, as well as the anhydrosis. Next we'll see the medial medullary syndrome. So here the paramedian region is involved, which is supplied by the branches of vertebral artery. So here the vertebral artery branches, which is mainly supplies that region, is involved. So any vascular lesion or thrombosis in this, okay, so in the midline, what do we see? We see the pyramid, right? So if the pyramid is involved, pyramid basically consists of the corticospinal tract, which is the motor tract. So there is contralateral hemiplegia, okay, so on the opposite side, because already they have crossed over, right? So crossing over has taken place, so it will be on the opposite side. Then hypoglossal nerve involvement. So because of the hypoglossal nerve involvement, there is ipsilateral, that is same side, okay, same side paralysis as well as atrophy of the half of the tongue, okay, because hypoglossal nerve, each side it will supply the tongue, both the intrinsic as well as the extrinsic muscles, except for halatoglossus. Yes. And then we have the medial lemniscus. So, medial lemniscus mainly consists of the sensory fibers, right. So, there is, because medial lemniscus is formed by the crossing over. So, always it is the opposite side will be involved. So, there is contralateral loss of position and vibration sensations as well as pain, temperature, all of that. Okay. So, this is about the medial medullary syndrome. Okay. So, it will involve this part. So, this is what we will see. Okay. So, there is same thing, contralateral hemiplegia as well as ipsilateral paralysis of the tongue only. Okay. Ipsilateral, one half of the tongue. Okay. One half of the tongue, ipsilateral paralysis and atrophy is there due to damage of hypoglossal nerve. So, this will be ipsilateral, whereas contralateral hemiplegia will be there. Okay. Only tongue is ipsilateral. This is contralateral because of the crossing over. Okay, both motor and sensory losses there. So, next we move on to the middle part of the brainstem, that is the pons. So, pons is about 2.5 centimeters in length. Now, this pons, it lies between the medulla here. So, this is the medulla, and above there will be the midbrain. And on either side of it, there will be this is the middle cerebellar peduncle, which will be connecting this pons to the cerebellum. So, because the pons, it forms a kind of bridge between the two cerebellar hemispheres. That is why it is called pons. Pons in Latin, it means a bridge. So, this pons, the dorsal surface, it also forms the upper part of the floor of the fourth ventricle. So, now we will see some of the features on its anterior as well as the dorsal part. So, on the ventral view, when we see a closer look of the pons, so here, so this is the ventral surface. Okay, so it will have two surfaces, this is the ventral surface and the dorsal, and it will have a superior and an inferior border. So, on the ventral surface, if you see, it is like convex in both directions, and it is striated, like transversely striated because of the underlying pontocerebellar fibers. So, pontocerebellar fibers will be running from the pons transversely towards the cerebellum. So, because of that, it is transversely striated. So, in the median plane here, we will see a central groove. Okay, so this groove we call it as the basilar groove, because the basilar artery will be present there. This is the basilar groove where the basilar artery will be lodging there. Then this nerve, if you see here, this is the trigeminal nerve. So, trigeminal nerve with a smaller sensory root, okay, will be lying medial. This is the motor root, okay, both the trigeminal, that is the fifth cranial nerve we will see here. So, it will be attached to the surface. Then if you see at the pontomedullary junction here, okay, where the medulla and the pons, we will see the vestibulocochlear, the abducent, the facial and the vestibulocochlear nerves. Okay, so from medial to lateral, we will have the 6th, 7th and 8th cranial nerves. Okay, the motor and sensory root is also seen. Sensory root of facial nerve, we call it as the nervus intermedius. So, that is also seen there. Right. So, in the dorsal part, okay, so in the dorsal part of the pons, if we see, so this dorsal part of the pons is basically forms the upper part of the floor of the fourth ventricle, okay, whereas the lower part is formed by the medulla. So, here we can see this median sulcus in the center. So, this will be the median sulcus. This is the median eminence, okay, on either side of it there will be median eminence. And this elevation which is formed here, we call it as the facial colliculus. So, this is basically formed by the winding of the facial nerve around the abducent nuclei. And here we have the vestibular area. So, these are the main features which we see on the dorsal surface of the pons. And when we see the internal structure, the internal features, so a cross section if we do of the pons at any level, we will see two regions. One is the large ventral part, which we call it as the basilar part, and the smaller dorsal or the tegmental part. Okay, so basilar and the tegmental part. Now this ventral, okay, so the ventral or this basilar part will be continuous inferiorly with the pyramids of the medulla, and on each side with the middle cerebellar peduncle. So this will be continuous with the middle cerebellar peduncle, and this will become continuous below with the pyramids of the medulla. Now the dorsal or the tegmental part, it will be a upward continuation of the medulla without the pyramids, okay, excluding the pyramids. So this basilar part of the pons is same. If you take at any level, the basilar part will be same. Only the tegmental part will differ. Okay, so we will be studying the pons at two different levels. So here in the basilar part, basically it consists of longitudinal bundles, okay, longitudinal bundles of fibers which is coming from the cortex, that is coming to the pons, which is corticopontine, coming to the nuclei of the cranial nerves, so called corticonuclear, and going to the spinal cord, corticospinal. Okay, so longitudinal fibers of corticopontine, corticonuclear, and corticospinal. So the corticopontine fibers, they relay in the same side, ipsilateral side of the pons. The corticonuclear fibers, they terminate. Okay, so corticonuclear fibers which pass through, they usually go to the opposite side of the opposite nucleus when they end. And corticospinal tract, they will also near the pyramid, they will cross over. Then in addition to this, there are transverse fibers, okay, which arise in the pontine nuclei. These are all pontine nuclei. Okay, these are all pontine nuclei, and they arise from this transverse fibers, okay, and they go towards the opposite side. They cross over to the opposite cerebellum, go to the opposite cerebellar hemisphere. So we call them as the pontocerebellar fibers. So pontocerebellar go to the opposite side. Then in the tegmental, okay, in the tegmental part, we will see many ascending and descending tracts there. So one is the trapezoid body, okay, so the ascending and descending tracts which we see in the tegmental part, okay, we will see the trapezoid body. So what is this trapezoid body? Trapezoid body is basically formed by the decussation of the ventral acoustic, okay, so the hearing, it is in relation to the hearing, okay, so acoustic striae, okay, so this is here, this is the trapezoid body which we see. Then we see the trigeminal lemniscus, okay, so trigeminal lemniscus, it basically carries the fibers of, that is second order sensory neurons, basically carrying the contralateral spinal nucleus as well as the principal nucleus, sensory nucleus of trigeminal nerve. So trigeminal lemniscus is formed by the second order fibers. So they are fibers of the second sensory neurons, okay, carrying the fibers from the opposite side, okay, opposite spinal nucleus and principal sensory nucleus of trigeminal. Then we have the spinal lemniscus. So spinal lemniscus is basically formed by the lateral spinothalamic tract, okay, anterior and lateral spinothalamic tract, basically carrying the pain and temperature sensations from opposite half of the body. Then we also have lateral lemniscus. So lateral lemniscus is basically the ascending tract concerned with hearing, okay, so this is with hearing. Then in addition to that, we will have the olivary nuclear complex also, okay, and we also contain the nuclei, okay, nuclei of, it also contains the nuclei of trigeminal, that is 5th, then 6th, then 7th and 8th cranial nerves, okay. So these are the things which we see in the tegmental part. So now we will study the pons at two different levels. One is a transverse section to the caudal part, okay, to the caudal part, that is at the level of facial colliculus. So at the level of facial colliculus, what are the things we will see? Now this is the basilar part. Okay, this is basilar and this is the tegmental part. Tegmental part. So now here, so basilar part is the same. So we know it has the pontine nuclei, then it has the corticospinal, corticonuclear and corticopontine fibers that are longitudinally running. So all these round things, they are all the longitudinally coming fibers. Then the transversely running will be the pontocerebellar fibers. Okay, so that we already know. So we will just concentrate on the tegmental part. So here the grey matter here, now if you see, it consists of the abducens nucleus. So this is the abducens nucleus. Now this elevation what we see here, right, this is the facial colliculus. Okay, this is the facial colliculus and this is the abducens nucleus. Okay, abducens nucleus is present and this is the motor nucleus of facial nerve. Okay, so this is the facial nerve. Facial nerve motor nucleus. Okay, so the fibers of the facial nerve, they will wind around the abducens nucleus forming this facial colliculus and then they will pass anteriorly, okay, between the facial nucleus and this one. This is the spinal nucleus of spinal tract of trigeminal nerve. Okay, trigeminal nerve. So this is what we see there. In addition to that, we also see closely here to the facial nerve nucleus. We will see the superior salivatory and lacrimatory nucleus are also present here. Okay, and superior salivatory, inferior salivatory and lacrimatory. Okay, so those nuclei are also present in relation to the tegmental part here. Then the vestibular nuclei. Okay, so these are the vestibular nuclei here, these two. Okay, vestibular nuclei are present in the vestibular area of the fourth ventricle, which I showed you earlier. And then we have the cochlear nucleus. These are the cochlear nucleus, that is the dorsal and ventral cochlear nucleus, okay, which are concerned with hearing, these are concerned with the balance. Then spinal nucleus, already told you. In addition to that, what is the white matter which we see? One is the trapezoid. Now this is the trapezoid body. So the trapezoid body here, it's basically a trapezium shaped mass of white fibers lying in the anterior part of the tegmentum. So it is basically formed by the decussation. There is crossing over of the fibers arising from this cochlear nuclear both sides. Okay, so the right side and left side cochlear nuclear fibers, they cross over and they form the trapezoid body. Then we have the medial lemniscus. Okay, so here this is the medial lemniscus. Medial lemniscus. So medial lemniscus is basically consists of the internal arcuate fibers, right? Fibers from the nucleus gracilis and nucleus cuneatus. So they will be carrying the sensations of proprioception, pain, okay, temperature, all of that will be carried by this medial lemniscus. Then we have the spinal lemniscus next to that. Okay, so this is the spinal lemniscus here. Okay, so spinal lemniscus is formed by the lateral spinothalamic tract, I told you. Then we have the medial longitudinal bundle. So the medial longitudinal bundle, we will see it here. Okay, so this is the medial longitudinal bundle. So I already told you, they contains fibers which interconnect the 3rd, 4th, 6th cranial nerves with the 8th and the 11th cranial nerves. So that is medial. Then medial longitudinal bundle. And this one here, this is the tectospinal tract. Okay, this is the tectospinal tract. And then we have the spinal. This is the rubrospinal. Okay, from the red nucleus. Tectospinal is from the tectum, that is from the midbrain it comes. Okay, so this is the rubrospinal. And spinal tract of trigeminal is senior. So this is what we see in the grey matter. This is at the level of the facial colliculus. Then through the cranial part, we will see a similar thing. Okay, little bit different here, a little change here. Okay, because in the lower part we saw that because it was forming the floor of the fourth ventricle, that it was the open part. But here we will see a small closed area here by the superior medullary vellum. This is the superior, enclosed by this superior medullary vellum. Okay, so here when we take in the upper part, or the cranial part of the pons, it basically passes through the trigeminal nuclei. Okay, trigeminal nuclei here. So now here what are the structures we will see? Okay, so the grey matter here will have, okay, so what are the things we are seeing here? This is the motor nucleus of trigeminal, and this is the sensory nucleus of trigeminal. Okay, these two we will see. So the motor nucleus as well as the principal or the main sensory nucleus of the trigeminal are seen. So this will be continuous in the caudal part with the spinal tract of trigeminal. Then we will see mainly the tracts. So this is a small portion of superior cerebellar peduncle here, because already the midbrain region will be merging here. So this is the superior cerebellar peduncle. And this is the middle cerebellar peduncle. Okay, so here the same thing, we are seeing this is, okay, so I'll just write by the first letter. So the medial lemniscus, the trigeminal lemniscus, then the spinal lemniscus and the lateral lemniscus. Okay, and in the thing we see the MTR, that is medial longitudinal bundle, tectospinal and rubrospinal, and this is the trapezoid body. So these are the things which we see in the upper part. Right. So now we will move on to the blood supply. Okay, so blood supply of the pons is mainly by the pontine branches. Okay, so the pontine branches of basilar artery as well as anterior inferior cerebellar artery. So these two pontine branches of basilar and anterior inferior cerebellar artery, which is a branch from basilar, will supply the pons. Okay, so the coming to the clinical correlation of pons. Okay, the first lesion which we see, or the first syndrome in relation to the lesion of the pons which we see in the lower part of the pons, if there is a lesion, it results in what we call as 𝗲𝗏𝗏𝗏 syndrome, which is also called as the medial inferior pontine syndrome. Medial inferior pontine syndrome. So this results from the lesion in the lower part of the pons. Okay, so lower part of the pons, basically, since it is present there, it involves the pyramidal tract too, as well as the fibers. We have the facial nerve and abducens nerve emerging from there. Okay, so it is in this part. Okay, so lower part, which includes this one. So here it includes, now this is the facial nerve, so this is the facial nerve and this is the abducent nerve. Okay, and this area basically involves the pyramidal tract. So because of which, what are we going to see? Because there is abducens nerve involvement, abducens nerve is the 6th cranial nerve, supplies the lateral rectus. So there will be on the same side medial squint. Okay, facial nerve. So facial nerve, there will be, because already facial nerve has emerged from the nucleus, so in the same side there is facial palsy. And corticospinal tract. Corticospinal tract still has to cross over at the pyramids, so it has not yet crossed over. So what happens? Contralateral hemiplegia. On the opposite side there will be hemiplegia. So these are the things which we see in the 𝗙𝗏𝗏𝗡𝗏 syndrome. The next condition is pontocerebellar angle syndrome. Pontocerebellar angle syndrome is basically here the anatomical structures which are located in the pontocerebellar angle, okay, which mainly includes the 7th and 8th cranial nerves. Okay, so if you can see, now this is the facial nerve. So this is the 7th nerve, 7th and 8th cranial nerves here. Okay, so because of the involvement of this as well as the flocculus, okay, it also involves the flocculus of cerebellum, that is flocculonodular lobe, right? Flocculus of cerebellum and choroid plexus of 4th ventricle. Okay, that is the plexus in relation to the 4th ventricle. So these things are also involved. Now, why does this pontomedullary syndrome occur? Okay, so the pontomedullary syndrome is basically due to the pressure exerted on the lateral region of the, pressure exerted on the lateral region of caudal part of the pons. Lateral region of caudal part of pons. Okay, so because of this involvement, so how this pressure is exerted here? Because of this acoustic neuroma. Okay, acoustic neuroma can cause pressure over this area. Acoustic neuroma can cause pressure over the lateral region of caudal part of the pons, and that will result in what we call it as pontomedullary syndrome. So this is basically a tumor which develops from the Schwann cells surrounding the cochlear nerve. Okay, that's why it's called acoustic neuroma. Now what will happen? Okay, so first is there is damage to vestibulocochlear nerve, right? So because there is damage to the vestibulocochlear nerve, it results in tinnitus and progressive deafness. Okay, progressive deafness and vertigo. Then the cerebellar peduncle is involved. Okay, because the cerebellar peduncle is involved, so there is ipsilateral ataxia and staggering gait. Facial nerve involvement, there is ipsilateral lower motor type of facial nerve palsy. And spinal tract and nucleus of trigeminal nerve, it is ipsilateral on the same side, pain and temperature loss. Okay, so that is what we see in relation to the pontocerebellar angle syndrome. So these are the signs and symptoms which we see. So if we know what are the structures which are in relation there and when they are involved, what happens, it is easy to remember the signs and symptoms. Then we have the next condition called pontine hemorrhage. So pontine hemorrhage occurs due to involvement of branches of, so it is basically the blood supply. Blood supply was by branches of, that is pontine branches of basilar and anterior inferior cerebellar artery, right? So these, when they are involved, it results in, okay, so when these arteries are involved, it results in pontine hemorrhage. So if the pontine hemorrhage, okay, it is bilateral and very extensive, then the patient will produce with these symptoms. So one is because of the involvement of the ocular sympathetic fibers, it results in meiosis, that is the pinpoint pupil. Then because of severe damage to the pons, okay, So because of the damage, there is 𝗲𝗵𝗃𝗂. That is because the regulating centers, okay, the pons is cut off from the regulating centers in the hypothalamus. So because of the damage to the pons, okay, the body basically, when I said pons is cut off, it basically means the body is cut off from the hypothalamus, because the regulatory center for temperature, body temperature is in the hypothalamus. Hypothalamus regulates the body temperature, right? So because of damage to the pons, the connection between the hypothalamus and below is lost. So because of which there is 𝗲𝗵𝗃𝗂. Then there is because of the reticular formation. So reticular formation is basically involved with the consciousness. Yes. So because of that there is deep coma. And because of facial nerve, so what will happen? Both the facial, because bilateral, here we are talking about bilateral. So both side facial paralysis as well as hemiplegia will be there, okay, paralysis. So that is about the pontine hemorrhage. And here one more word is about one of the most common tumors, okay. Just remember that most common tumor of brainstem, okay. Most common tumor of the brainstem is basically the astrocytoma of Pons. So this is basically seen in childhood. So signs and symptoms basically depends upon which area is involved. Now we will study the upper and the uppermost and the shortest part of the brainstem, and that is the midbrain. So midbrain, when we see here, it is only about 2.5 centimeters long and 2.5 centimeters in width. So this midbrain, it connects the hindbrain with the forebrain, and its cavity we call it as the cerebral aqueduct. So cerebral aqueduct will be connecting the third ventricle with the fourth ventricle. So when we see the ventral part, okay, so this is a closer view. So the ventral surface of the midbrain will consist of two crura cerebri, okay, consists of two crura cerebri. So this crura cerebri, they emerge from the cerebral hemisphere and converge downward to enter the pons. So these crura, they form what we call it as the boundary, okay, boundaries, posterolateral boundary of the interpeduncular fossa. So here the superficial surface of the crus cerebri is very finely corrugated, you can see here corrugated by the underlying longitudinal fibers, and here it is crossed transversely from above downwards. So this is the optic tract, okay, here optic tract is there. This is the optic tract, and then it is crossed by the posterior cerebral artery, the superior cerebellar artery, okay, and then tinea pontis. So these structures from above downwards will be crossing the midbrain transversely. Then here if we see, this is the oculomotor nerve, okay, oculomotor nerve will emerge from a groove on the, so this is the crus cerebri, so there is a small groove on the medial side. From the medial side we will see the oculomotor nerve. Then this is the trochlear nerve. So trochlear nerve emerges on the dorsal aspect of the midbrain, and then it comes on to the posterior, okay. So it's a long nerve, so from the dorsal it comes to the front, that is to the ventral, which we can see here. Next the dorsal surface, okay. So when we see the dorsal surface of the midbrain, it presents these four, okay, rounded elevations. They are called as corpora quadrigemina, okay, corpora 𝗕𝗵𝗄𝗡. Okay, so they are formed by nothing but two superior colliculi. So these two are the superior colliculi. And these two are inferior colliculi. Okay, so the superior and inferior colliculi. And here in between, the superior and inferior colliculi are separated by this cruciform sulcus. So here, if you trace this sulcus above, it forms a depression here. Okay, and here in this depression, we will see one gland. This is called the pineal gland. Or the pineal body it is called. Okay. And when traced below, it becomes continuous with the frenulum villi. Okay, so here down. Frenulum villi will be here. Okay, it's a median ridge which we see on the dorsal surface of the superior medullary vellum. Next, so this is a little bit. So basically here from the lateral, okay, so along the lateral side, thick ridges of white matter, they will extend along the lateral side of this midbrain. So they extend from each of these colliculi, okay, and they are called as the brachii. So the superior brachium, so superior brachium will be connecting the superior colliculus to the, okay, so superior brachium will be connecting the superior to the lateral geniculate body, whereas the inferior brachium will be connecting the inferior colliculus to the medial geniculate body. So the superior brachium will be connecting the superior colliculus to the lateral geniculate body. So it will be containing the lateral geniculate body as well as to the optic tract. So it will be containing the optic fibers. So superior geniculate body, optic fibers, okay. Whereas the inferior geniculate, so they will be connecting it to the medial geniculate and they are made up of auditory fibers. Okay, so next we will see the internal structure. So the midbrain consists of the grey matter and the white matter. So the grey matter is in the form of superior colliculus, inferior colliculus, the red nucleus, substantia nigra and nuclei of oculomotor and trochlear nerve. White matter is in the form of ascending and descending tracts and the cerebral peduncles. Okay, so here you can see these are the cerebral peduncles. Okay, this is the ventral surface, so you won't see the, what is that, colliculi, you will see it on the dorsal. So here you can see the oculomotor, that is the third cranial nerve, and trochlear, that is the fourth cranial nerve. So coming to the internal structure of the midbrain, so there is a tiny canal here. So this canal is called the cerebral aqueduct. Okay, cerebral aqueduct. So we will draw a coronal plane passing through the aqueduct. It will divide this midbrain into two parts. A smaller posterior part, so this is the smaller posterior part, which we call it as tectum, and a larger anterior part, okay, this is the anterior part, which we call it as the cerebral peduncle. Cerebral peduncle. Now this cerebral peduncle will have three portions here. This is the tegmentum. This is the substantia nigra. And this is the crus cerebri. Okay, crus cerebri. So these are the three portions which make up the cerebral peduncle. So this tectum part, okay, so in the tectum part we will have the four colliculi, that is the superior and the in pair of superior, pair of inferior colliculi. So this larger anterior part will be divided by this vertical plane here. okay, vertical plane, and each of these cerebral peduncle is further divided into, that is into two cerebral peduncles, and each of that is divided into three portions: tegmentum, substantia nigra and crus cerebri. So the crus cerebri here, okay, so the crus cerebri is the part of the cerebral peduncle which is situated anterolateral to the substantia nigra. So this contains, okay, this contains the descending tracts which connects the cerebral cortex to the anterior horns of spinal cord, then cranial nerve nuclei as well as pontine nuclei. We saw that in the Pons, right? So the corticospinal, corticopontine and corticonuclear tracts. So here we have to see that this corticospinal and the corticonuclear fibers, okay, which make up the pyramidal tract fibers, they occupy the middle 2/3. So middle 2/3 is by the here 2/3. So middle 2/3 here is by which one? The corticospinal and corticonuclear. Okay, corticospinal and corticonuclear fibers. Whereas the frontopontine, okay, from the frontal lobe to the pons, they occupy the medial 1/3. This is the frontopontine. And the remaining from the other regions, okay, that is the temporopontine, the parietopontine and the occipitopontine, they will occupy this lateral, okay, temporo, parieto and occipito. All pontine fibers will be at the lateral part. So that is the crus cerebri, which is also known as basis pedunculi. Okay, then we have the substantia nigra. So this is the substantia nigra. So substantia nigra, when we see here, so this was the crus cerebri which we just learnt. So next coming to the substantia nigra. So this is the substantia nigra. So if you see, it is a very curved and crescentric, curved and crescentric shape. Okay, crescentric shape. So here it is highly pigmented. Okay, it's a pigmented grey matter. This is substantia nigra. So it is pigmented grey matter. So this is situated between the tegmentum and the crus cerebri part. Okay, so it is located between those two things. And this substantia nigra, right, it contains, basically it is a very large, it is a large motor nucleus. Motor nucleus which is present all through the midbrain. So it is divided into two parts. Okay, so this substantia nigra is divided into a ventral part and a dorsal part. The ventral part here, okay, so the ventral part of it is called pars reticularis. Okay, ventral part is called pars reticularis. Pars reticularis. Okay, this contains less number of cells. Less cells. Whereas the dorsal part is called pars compactum. Pars compactum and or pars compacta, it is called, and it contains more cells as the name suggests. So substantia nigra is made up of deeply pigmented cells which we call it as the melanin. Okay, so this melanin is nothing but a polymerized form of dopamine, and also it contains iron. Okay, so the substantia nigra is made up of this pigment containing melanin and iron. So these cells, why these cells are important is they produce dopamine which is carried through their fibers, that is nigrostriatal fibers. to the corpus striatum. Okay, so from here to the corpus striatum through the nigrostriatal, substantia nigra to corpus striatum, nigrostriatal fibers. So this produces dopamine and dopamine is carried. So basically the degeneration of this, it results in what we call it as Parkinsonism. Right. Next we have, and then when we see these, okay, these are all the tracts, the white matter which consists of the medial, so we already know about it, medial, trigeminal, spinal and the lateral lemniscus. This is the nucleus of inferior colliculus. Okay, this is the inferior colliculus. And here we see this is the trochlear nucleus. And here we have the mesencephalic nucleus of trigeminal. So these are the things which we see. And this is the decussation here of the superior cerebellar peduncles. Okay, so this one is the decussation of superior cerebellar peduncles. So here we studied the section. So whatever I explained so far, this was about the structures at the level of the inferior colliculus. So here I would like to mention that is the trochlear nerve here is situated close to the median plane here if you see, and the emerging fibers of the trochlear nerve, they will pass laterally and posterior, okay, to the medial longitudinal bundle, and then the fibers of the trochlear nerve, they decussate here. This is the superior medullary vellum, so you can see it, they are crossing over here, okay, so they decussate and wind around the lateral aspect of the midbrain, and then they come to the, from there they will enter the trochlear nerve, passes through the lateral wall of cavernous sinus. So that is the thing. Then here we see the mesencephalic nucleus of the trigeminal. So mesencephalic nucleus basically receives the proprioceptive impulses, okay, proprioceptive impulses of mastication and from the teeth, from the ocular as well as the facial muscles. So that is the function of the mesencephalic nucleus, receiving the proprioceptive impulses from muscles of mastication, the ocular, from the teeth as well as from the facial muscles. Okay, so here this one, this is the grey matter here which we see under the inferior colliculus, which forms the nucleus of inferior colliculus. So this will be receiving the fibers from the lateral lemniscus. So you can see this is the lateral lemniscus. So it receives the fibers from this lateral lemniscus. So from here it receives the efferent fibers, and from there it gives the efferent, okay. It receives the efferent and gives the efferent to the medial geniculate body, and that passes through the inferior brachium. Then rest of the things I already told you there. So that is about the section at the inferior colliculus. So next we study the TS of midbrain at the level of superior colliculus. So here it is almost the same. So here what happens is the central grey matter will again have, if you see, two nuclei. Here we can see one is the oculomotor nucleus. Okay, this is the mesencephalic nucleus. Nucleus of trigeminal. Okay, in addition to that we will also see this is the oculomotor nucleus. Okay, oculomotor. So this is the oculomotor nerve. Okay, so the third cranial nerve here. So this oculomotor nucleus, it lies in the ventromedial part. Okay, and the two nuclei, they fuse together forming a single nuclear complex here, and on either side it will have this body. This is known as the 𝗕𝗵𝗄𝗏 nucleus. So 𝗕𝗵𝗄𝗏 nucleus mainly supplies the sphincter pupillae and the ciliary muscle. Okay, so that is the things which we see here. So here we see the superior colliculus. So superior colliculus here formed by this superior collicular nucleus. Okay, so it receives basically the afferent fibers from the retina. Okay, so from the retina, then spinal cord, that is basically through the spinotectal tract, and then it will also receive the frontal and occipital, okay, visual cortex from the frontal and occipital, that is basically for the conjugate eye movements, and also from the inferior colliculus. So it will receive. Okay, so from here the fibers, they form the tectospinal. Okay, efferent fibers, they basically form the tectospinal, tectobulbar tracts, and they are responsible for the reflex movements of eye. So what happens in relation to visual stimulus, our eyes move, our head moves, right? So those movements are basically due to these tectospinal, tectobulbar tracts. Okay, so they bring about that. And from the superior colliculus, the efferents, they go to the through the superior brachium, they will be going to the lateral geniculate body, so carrying the optic fibers. Right. So that is all about the transverse section of midbrain at the level of superior. Rest of the structures remains the same. So the blood supply of the midbrain, the arterial supply is by the, so it's always we say venous drainage and arterial supply. So arterial supply is by the posterior cerebral artery and superior cerebellar artery. Okay, posterior cerebral and superior cerebellar artery, whereas the venous drainage is basically into the basilic vein and the great cerebral vein. So the blood supply, as I said, supplied by the basilar artery. This is the basilar artery through its branches, that is the posterior cerebral and posterior cerebral and superior cerebellar arteries, and branches of posterior communicating. So here we will have the posterior communicating, and anterior choroidal arteries. Okay, so anterior choroidal arteries. So these are the arteries which will be supplying the midbrain. Venous drainage is mainly into the basilar vein and the great cerebral vein. So there are two syndromes in association with lesions of midbrain. So one is the Weber's syndrome. So the Weber's syndrome is produced by a vascular lesion in the basal region of the cerebral peduncle. Okay, and this is mainly due to occlusion in the branch of the posterior cerebral artery. So occlusion of posterior cerebral artery results in Weber's syndrome. So here the lesion involves the oculomotor nerve and the crus cerebri. So what will happen there? So because it involves the crus cerebri as well as the oculomotor nerve will result in ipsilateral lateral squint, okay, due to the involvement of the third cranial nerve, that is the oculomotor nerve. And corticospinal tract, okay, corticospinal tract here, because of which the opposite side, so contralateral, there will be hemiplegia. Corticobulbar, contralateral paralysis of the lower part of the face and tongue, okay, and paralysis of levator palpi, because that is also supplied by the oculomotor. There is ptosis, drooping of eyelids, and 𝗤𝗏𝗏 nucleus is involved, so pupil is dilated and fixed to light, and accommodation is lost, okay, on the same side of the lesion. So that is the signs and symptoms of Weber's syndrome. So Weber's syndrome, this is the area involved, okay. So that is why the oculomotor nerve here, the corticospinal tract, okay. Next, okay, so this is the area involved in Weber's syndrome. Next we have Benedict syndrome. So this is basically ischemia of the tegmental region, tegmentum region, okay, tegmentum region. So 𝗣𝗿𝗸𝗀 was in the basilar region, so this is in the tegmental region, and okay, so here it involves, so here also tegmentum region means it involves this region, okay, so all this region tegmentum, this is tectum here, so this is the tegmentum. So this region we have the Benedict's K with the K here syndrome. So Benedict's syndrome, what are the things we will see? Because the oculomotor nerve is involved there, so there is ipsilateral squint because of the unopposed action of the lateral rectus there, okay, and ptosis because of the paralysis of levator palpebrae superioris. Trigeminal and spinal lemniscus. Now trigeminal and spinal lemniscus, okay, so trigeminal from the face, so contralateral loss of pain and temperature sensation from the face, and spinal lemniscus from the contralateral side of the body, the pain and temperature sensations are lost. Medial lemniscus, so this is 2-point discrimination, joint sensation, vibration, motion, okay, so movement, sensations, so these are lost tactile by these medial lemniscus because of the involvement of that. Then there is red nucleus and fibers of superior cerebellar peduncle, so because of which there is contralateral tremors and involuntary movements are there, okay, so that is this part. So we are seeing the involvement of trigeminal, the spinal lemniscus, okay, as well as the medial lemniscus. This is the red nucleus which is involved. So this we see in Benedict's syndrome. Then there is one more syndrome here which we call it as the Parinaud's syndrome, okay. So Parinaud's syndrome is basically because of the lesion of superior colliculi, okay. So this happens when this area gets compressed by tumors. So basically this involves the tectal region, okay. So these tumors are mainly due to the pineal gland tumors. So it involves this area. So what do we see? Because the superior colliculus is involved there, so there is loss of upward gaze, okay, without affecting the other eye movements. So another thing which we see in relation to the lesions here is the Ārgyll-Robertson pupil, okay, Robertson pupil. So what is Ārgyll-Robertson pupil? So here there is, it's a clinical condition where the light reflex is lost but accommodation is there, okay, accommodation reflex is intact, accommodation reflex is intact. It occurs because of a lesion in the pretectal, in the region of pretectal nucleus. So this is all about the lesions of the midbrain. So let us look at some of the image based MCQs. The structure located ventral to the cerebral aqueduct and medial to red nucleus is, okay, so this is the red nucleus and this is, so what is this structure? It is the oculomotor nucleus, okay. 𝗲𝗏𝗃𝗃 nucleus is only here in this region, but since it is a red nucleus and it is located, medial to that, it is oculomotor nucleus. So which structure is spared? So here actually they are asking is this lesion. So it is the hypoglossal, here it is, okay. So in this portion it is the hypoglossal nucleus which is spared, that is in the lateral medullary syndrome. So this elevation is formed by the facial nerve looping over the adjacent nuclei, okay. So facial, this is known as the facial colliculus. So this is the elevation they are asking. So facial colliculus. So it is the facial nerve fibers looping over the adjacent nucleus. Fibers located medially within crus cerebri. So medially here we have the cortico-spinal and corticonuclear. This is in the 2/3 region. Then 1/3 here we had the frontopontine, and here we had the remaining temporopontine, parietopontine. So in this medial it is frontopontine. Which clinical finding is most consistent with this lesion? Okay, so here this lesion they are asking. So it is the contralateral spastic paralysis of the body because of the involvement of pyramidal tract. So that's a wrap on today's session of brainstem and brainstem lesions. So stay focused, stay consistent, because every revision series is one step closer to your NEET PG dream. So I'll see you in the next session.